outline will cover since the background, what we know now from the molecular biology, the potential biomarkers, and their clinical implications. To start, I have to say the intracranial aneurysms are very severe disease. They have serious implications in a patient's life. Because its most common presentation is the bleeding, because it causes ruptures. It causes a higher mortality and high morbidity, when 30 to 50% of the patients die of the first episode of subarachnoid hemorrhage. 40 to 50% of the survivors have significant neurological deficits and with severe disability. We could estimate that 2 to 6% of our population has or could harbor intracranial aneurysm. Just to mention, only in the USA, each year more than 28,000 people have subarachnoid hemorrhage caused by aneurysm. This causes a higher impact in economics with higher costs, and just to mention, to treat only 118 patients, the costs are almost $3 million. On the flip side, on the other side, is the intracranialism rupture, or means when they are diagnosed before the rupture. Unfortunately, it's not the most common way to diagnose it, but when we could, its operative mortality is lower than 2.5% and morbidity less than 6%. Its cost is lower than the rupture ones, 1/3 or less. So what we trying to show today, how to use biomarkers to find the aneurysm at this stage and provide a better treatment for our patients. Until now, the risk factor for intracranial aneurysm are age over 50, cigarette smoking. Even the light smoker has a higher risk than the non-smokers. Alcohol consumption, sex hormones, especially estrogen has a protective level. I will discuss on this briefly. Systolic hypertension, and these are the only ones. And what's the challenge? Because with these epidemiological factors, we can provide a higher predictive power to identify who is at a higher or elevated risk to harbor aneurysm. So there is no cost effectiveness to do a pre-symptomatic screening on this population. That's why potential biomarkers are needed, and I will show you what you already know, which one could be used in our clinical practice. What you know now is that there is an important role of inflammation that, coupled with genetic factors in the patients that have the epidemiological risk factors, they could develop aneurysm and it could rupture. So we already know the risk factors. Now is how to make more clear the genetic and the inflammation ones. So let's start with genetic factors. First one, there is no single gene for intracranial aneurysm. And we know that genes are crucial understanding for any disease today, because they allow for better screening and to know better who is need for treatment. And we know that there are familial predisposition for intracranial aneurysm. Twins and relatives have an early onset and 7 times more subarachnoid hemorrhage. Siblings, 6 times increase to have the same disease. And first degree relatives 3 to 7 times higher than general population. So genetics is very strong for intracranial aneurysm. So we have some clues coming from our new studies. For instance, in the chromosomes 8 and 9, there are strong association with the ones that are smokers. And there are some regions in the chromosomes 7 and 19 and the Japanese and white patients. We know for a larger study that has more than 6,000 of patients with aneurysm and 14,000 controls. There are 3 new loci in the chromosomes 18, and 10 that are associated in intracranial aneurysm. Another interesting gene that is being studied a lot is the elastin gene that is upregulated or expressed in the formation of intracranial aneurysm, and they are located in the chromosome 7. Well, the problem is that these genes that I mentioned there are not so accurate to make a diagnosis. So we have new tools or new findings that we can use. One of the most interesting are to identify differentially expressed genes of unruptured intracranial aneurysm, because we know there are some genes that are expressed during a specific cascade for inflammation, for any process in our body. And we can identify using the technique of genomic microarray analysis. We can identify the hub genes, for instance, MYH11 and these others. They are related to vascular smooth muscle contraction. RUB genes are genes that receive a lot of connection for other genes, and they are the one that orchestrate the process, in this case, the formation of the aneurysm. We can see here the gene, this is the RUB gene. It receives all the information of the other genes, the one that make the signal to start the process. And the process here is the smooth muscle contraction that I will show in a minute how this is important for the formation of the aneurysm. Another interesting fact comes from our knowledge from inflammation. We are understanding more and more with advanced molecular biology the role of inflammation in aneurysm, intracranial aneurysm. We know that everything starts from an endothelial dysfunction that comes to a vascular smooth muscle contraction and modulation, causing an inflammatory response that, when this response is not well regulated, it causes apoptosis of the cellular constituents of the vessel wall, degradation to extracellular membrane, aneurysmal dilatation, progression, and rupture. We can see more clearly now. We start with at the endothelium, comes to vascular smooth vessel cell. Then there are inflammatory response that is very, very higher. There are a lot of cytokines that I mentioned briefly, and a lot of cells that come to cause the formation of the aneurysm and rupture. Here we see more clearly that during these steps, there are a lot of candidates to be biomarkers to identify what is happening and to make an early diagnosis. Here, the first important find is that before its rupture of the aneurysm, there is an infiltration of the vessel wall by macrophages and T cells and mast cells. And even these are allowing some researchers to study the administration inhibitor, for instance, of mast cell that blockade the inflammatory response, and in this study, the progression of the aneurysm was also halted. So if you could identify macrophages and these cells, and I show how, we can make early diagnosis of the ones that are prone to rupture. Here, just to remember where they are in the cascade of the aneurysm formation. Another interesting finding are about the interleucins. There are several cytokines that are involved in the process of aneurysm formation. The most important are the interleucin 1, 6, tumor necrosis factor alpha, and nuclear factor kappa B. And they are strongly related with this process of inflammation that causes vessel dilatation and rupture. We can see clearly that are a lot of interleucins involved in this, and there are some founds that are great to discuss here. The first one is the cytokine interleucin 1. Its level in the plasma, it's an independent prognostic biomarker of poor neurological outcome after rupture. So we can use it to identify who you have a poor diagnosis after the rupture, and information that we don't have today with the technology, other tools that you have in our clinical practice. So it's very important found. Here you can see clearly that it allows a accurate diagnosis on which ones will come to a poor diagnosis, unfortunately, for the outcome, sorry. Another potential biomarkers are the metalloproteinases, because they contribute to breakdown of the extracellular membrane. And we know that the levels of the MMP2 and 9 are higher in rupture compared with a rupture aneurysm. So if you are following a patient that has an aneurysm that we were not treated for a reason or another, and these levels can predict its rupture. And the TNF alpha of tumor necrosis factor alpha, it continuous expression induced aneurysm rupture because it's orchestrates all the inflammatory response. So if it's reduction stabilize aneurysm, there are a lot of studies of new drugs that blockade the TNF alpha and with promising results in aneurysm progression. We can see here that TNF is at the beginning of the process, and its blockade could be absolutely beneficial. One of the most interesting finds of the last years are the found that the RNA expression of circulating neutrophils carries a intracranial aneurysm associated signature. Neutrophils are the most common cells in the immune response, inflammatory ones. And we know now that when they are doing an inflammatory response toward aneurysm, its RNA expression is different. And when this RNA was extracted from these neutrophils, we can even make a very accurate diagnosis of one that harbor aneurysm or not, even in a blind study. So this signature was able to separate who harbor or not aneurysm with a very promising use. And if we can do this, we can even found one is at risk, follow it before its rupture, and treat in a better scenario. Here you can see clearly how this technique differentiates who has an aneurysm, intracranial one. So with this knowledge of molecular biology, I only teach you briefly. There are more knowledge on this. We have clinical implications, and I start saying about what implications in diagnosis to identify who has the change or who has an aneurysm. We can use, as I mentioned, as promised tools to differentially express genes to identify the HUB gene that make early diagnosis, early treatment, as the same for the RNA expression intercirculating neutrophils. With this, we can predict aneurysm occurrence and treat patients very early. And on the other side, with the interleukin-6 levels, we keep looking for a predictor of the outcome when aneurysms cause always rupture, or had rupture, sorry. And as I mentioned, there is a progression or a strong activity of inflammatory cells in the aneurysmal wall before its rupture. And one of the most common are the macrophages. And there is one drug called ferromoxetol that contains iron oxide nanoparticles that can see an MRI sequence. And this can be used to follow on rupture aneurysm and any activity that precludes rupture. So you can see here how this contrast enhancement changes when the aneurysm are prone to rupture. And this is a good tool to make a decision to treat the patient in the proper time, avoiding complications or even death. For the treatment, these insights for molecular biology are promoting larger studies in drugs that could help our patients. Just to mention, one of them are imidapryl. It's an angiotensin converting enzyme that it's a inhibitor of metalloproteinase 9 and strongly suppress the size and medial tiny of induced intracranial aneurysm. You can see here, when using imidapryl, the vessel wall maintains and not goes to thinning more and more, as we see in this case. So it's a very, very promising drug to avoid aneurysm rupture. Another one is angiotensin, because we know that angiotensin 1 and 7 attenuate aneurysm rupture and mortality. There are some drugs that improve its use, and they become more and more available to avoid a rupture. So it probably will be useful in our clinical practice. We can see here the aneurysm decrease a lot in subarachnoid. And the last but not least, important implications of our knowledge in molecular biology is in prevention. The estrogen protects several components inside the arterial wall and inhibits some of the inflammatory molecules. That's why you see that at menopause, the incidence of aneurysm increases a lot. So we can see that women that are submit to hormone repository therapy, they have a lower risk of developing intracranial aneurysm. So we have to encourage the woman in their age or in the situation of menopause to use estrogen therapy if they have no contraindications for it, of course, because it decreases a lot the risk of intracranial aneurysm. So with this in mind, we can conclude that intracranial aneurysm still remains a catastrophic disease with a high morbidity and mortality. There are a lot of endeavors open for prevention, diagnosis, and treatment. Molecular biology of intracranial aneurysm advanced a lot in the last years, improving its understanding of etiology, history, and especially to find for potential targets and potential biomarkers to be explored in its prevention, diagnosis, and treatment. That's why our work to looking for potential biomarkers are needed, and because they promote early diagnosis, early treatment, and the patients will do well without the bad situation, the bad outcomes when they rupture. If you have any questions, please let me know, and thank you for your attention.
Hello, Dr. Jose. Thank you for a wonderful presentation.
Yeah.
Are there any questions for Dr. Jose's presentation?